this point, I would like to introduce our first morning speaker, Dr. Andrew Plaut, whose topic today will be the treatment of gastrointestinal problems in the scleroderma patient. Dr. Plaut is board certified in internal medicine. He has a special expertise in gastrointestinal issues including diarrhea, inflammatory bowel disease, or IBD, and malabsorption issues, such as those seen with scleroderma. Dr. Plaut is a graduate of Tufts University in Boston, is now affiliated with Tufts Medical Center and Christiana Healthcare Services. He has 49 years of experience and has contributed to 86 publications. Please welcome our good friend, Dr. Andrew Plaut.
I'd like to thank the foundation and Rebecca and Ann and Jack for inviting me here to speak again. Who I am is I'm an internal medicine doctor. I do lots of research in areas that are touch on scleroderma, but not quite in the middle of it. And I see a lot of patients with disorders of the gastrointestinal function who have scleroderma. And I will just mention that my interest in this came about from a patient who came to see me about 25 years ago. Some of you would know the name of this person, which I'm not going to name her, but she came to me and said, I've been to 3 doctors and nobody knows anything about how to solve my problems with scleroderma. So I looked at this patient as somebody not only who needed my help, but as a real opportunity to get involved in helping people with this disorder. And some of my patients are here today, and it's always great to see them. And so let me tell you how I'm going to proceed today. When I spoke here 2 years ago, I started at the oral cavity and went right down through the esophagus, the stomach, the small intestine, the large intestine, and so forth. And it's a little trip through the gastrointestinal tract, which I really like to take, and I kind of do that every time a patient walks into my office, because gastroenterology is the one field that I know of that you can treat just about everything that comes your way. All you have to do is know how the system actually works. And I teach medical students and gastroenterology trainees about this. And when they're done, I hope they really do know how it works, because that's how we approach the problems that occur in scleroderma. Now, what I'm going to talk about today, I'm going to talk about 2 topics in a little more depth than I usually do. One is Sibo. Anybody ever heard of Sibo? Small intestinal bacterial overgrowth. If you've heard the word Sibo, raise your hand just for a second. Now, finally. But it would be my guess that most of you don't know exactly what Sibo is. And we're going to go through that. And the second thing I'm going to talk about, and this is a warning to anybody who doesn't want to hear about the lowermost end of the gastrointestinal tract, time to go out and call your family and have another cup of coffee. I'm going to talk about the anus and rectum. That's the way it goes. That's what GI docs do. All right. Now, the gastrointestinal tract and scleroderma, my first slide is already here, which is very advantageous. I'm going to point over here. The problems are treatable, as it says here. They can be a real nuisance, obviously. And they're present in just about all forms of scleroderma, be it limited disease or generalized systemic scleroderma. The principle of everything that we're trying to do in helping people who have gastrointestinal problems is that the problems are largely ones of movement. That is, the nerves and the muscles of the gastrointestinal tract from top to bottom often don't work well in patients with this disorder. So we have to deal with that, and it helps us understand a lot about what's going on. The good news, as I have down here at the bottom, is that many gastrointestinal functions in this disorder are perfectly normal. Just to compare this, people who have an illness that I deal with quite a bit, which is ulcerative colitis and Crohn's disease and so forth, which also causes lots of gastrointestinal problems, those people have abnormalities of inflammation and dysfunction of the lining of the gut, which are paramount. That is not the case in patients with scleroderma. Patients with scleroderma, and I'll have to group you all together for the purpose of this talk, have problems in the way that the gastrointestinal tract moves, how its nerves work, and how its muscles work. And that's what I want to talk to you about today. And then I will move here. One of the things, I'm going to skip right down to here, this thing that I have right here in the middle. By the way, I'm going to take my watch off so I don't go overtime. In recent years, there's been a great deal of work done on what's called the microbiome, that is the microorganisms that live in the gastrointestinal tract. And I'm going to be talking about those when I talk about Sibo. But the main point is that they are very highly localized in the gut. And I'll tell you about that in just a moment. The problems with bacterial overgrowth, which I will discuss, are often overlooked. And if most of you are going to the regular, even well-trained internal medicine physicians for your care, it's very easy to overlook what's happening with these microorganisms that are in the wrong place in the gastrointestinal tract. I'll define that in a moment. But these are treatable issues, which is always nice. You want to help people if possible. Now, I'm going to start talking about Sibo, or bacterial overgrowth, and by the time I'm finished, which is going to be in about 10 or 15 minutes on this particular topic, I'm hoping that you all understand what the basic issue is, because that helps you understand, hopefully, how this can be treated and how to discuss it with your own physician, who may not be clear about this. So, you see these terms here, Sibo, PNH, CLL, BUN, AST, and so forth. This is medical jargon. There's hardly any doctor in the audience or out there would have any doubts about what these things actually mean. But Sibo is another one. So what is it? It's small intestinal bacterial overgrowth. Now in this disorder, there's a problem that is not what bacteria are present in the small intestine, but why they're there in the first place. Here's the numbers we're talking about. Right now, as you're sitting here, your large intestine, which is the lowermost part of your gastrointestinal tract, contains an astonishing number of microorganisms. What's an astonishing number? It's 10 to the 12 microorganisms. That's 10 multiplied 12 times. That is 100 billion microorganisms. That's what's there. They're normal. They should be there. If you disrupt them too much, you get sick. And there's a whole field of the microbiome, which hopefully if we meet again in subsequent years, I'll be able to discuss that with you in a little more detail. So how many microorganisms are present in your small intestine now if you have a normal small intestine? And the answer is probably 10,000 per cubic centimeters. Cubic centimeters, half a teaspoon. If that number is considered by people who study the bacteria in a bowel as being sterile, 10,000 bacteria. Because if you're dealing with hundreds of billions of bacteria, we're talking relative sterility. So what is the problem in patients who have Sibo, or bacterial overgrowth? So to see that, let's have a look at the small intestine of a normal individual who does not have a motility problem in the small intestine. You can see here, this is a normal intestine filled with barium, so it has an imaging, we get a good image of it on an X-ray. And the loops are kind of close together. They're happy. They're not enlarged. And this is a place where bacteria cannot live. And the reason they can't live there is because this is constantly moving. The small intestine empties itself through a coordinated contractile mechanism about once every hour to hour and 15 minutes. It's a complete evacuation of what's in the intestine, and bacteria can't tolerate that because they're living in a flowing stream. Now, if the stream stops flowing, as it does in many people who have scleroderma, we're dealing with something else, and that is a gastrointestinal tract that is dilated. These loops are too wide. The gut of the small intestine is not moving properly, and therefore this is a place where bacteria can grow. Now, as with any static place, if it's not moving properly, as with any problem in the intestine, which leads to slowing of movement of its contents, bacteria will live there. They like it. It's warm. There's food. There's everything that they'd ever want. And that's why they live there. Now, you can get this in people who have little pouches off of the small intestine called diverticula. You can get it in people who have cancer that involves the small intestine because the intestine can't move contents past a tumor or scarring from a tumor. But in Scleroderma, the gastrointestinal tract is basically normal. It just can't move properly. And we can deal with that. We have to, first of all, think about it. This is just another example. This is just another example of a gastrointestinal, small intestine in Scleroderma that's dilated, and bacteria can live here very easily. Now, the next slide I'm going to show you is going to be a puzzle for you. And why am I showing you this? This is a person washing his or her hands. Does everybody know how soap clears grease off of your hands? Okay, I'm going to show you. If you've just fixed your car, as I hope some people know how to do, I don't, you're coming up with a lot of grease on your hands, and you've got to get it off. If you run it under a tap with water, will it come off? No. Water and oil don't mix. So, many thousands of years ago, people recognized that there was something called soap. I will get back to that in a moment. I've already told you what was on that slide. This is what soap really does to grease. Very simple. Here's a glob of grease, and this is soap. And what these are is they are long chain, essentially what we call long chain fatty acids. They are fat themselves. So soap is fat that interacts with fat, and water and oil don't mix, but oil and oil mix very well. So this is how soap actually works. Now, why am I showing you this rather odd picture? And I just want to tell you, we're going to go back to Sibo right now as to why bacteria in the gastrointestinal tract interfere with the ability of the gastrointestinal tract to handle fat in the food. What's fat in the food? Anybody who's ever done any cooking here, which does not include me, by the way, will recognize fat globules on the surface of chicken soup, or soon-to-be chicken soup. These round things you see here are globules of fat. If you swallowed these, and you'd probably do it all the time when you're eating soup, those globules of fat will roll right down the gastrointestinal tract, go out into the stool. Your stool will probably turn kind of white like fat can be, and you won't be able to absorb it. But we know it's absorbed because you can look at normal people, and they really can absorb fat in large amounts. So how do they do this? Well, it's a form of soap in the gastrointestinal tract, and I'm going to tell you what that soap is, and that is this. Now, this structure will not be obvious to most of you people here, but this is a structure of something called a bile acid. And this material is present in your gastrointestinal tract. After your gallbladder contracts, there's even more of it. And when you eat fat, this substance appears in your small intestine. Now, there's two parts of it that are important. One part is this part right here, which is fat. It's called a sterol, in case anybody's interested in chemistry, but there it is. And up here, there's ions like oxygen and hydrogen and so forth, which are water-loving. So this is a fat-loving part of the molecule, and up here is a water-loving part of the molecule. And the bile acids work just like soap to remove grease. They interact with lipids that you eat in food. And what they do is they'll take a fat particle And these bile acids, which I'm now showing here in this little yellow diagram, by the way, if you're looking over here, you're not seeing my pointer, but I need a forked pointer. That's a good invention, by the way. Maybe one of the Harvard Catalyst people can come up with that. This is that bile acid that I just showed you. That's the water-loving part, and that's a fat-loving part. And when those bile acids get together, they form what is called a micelle. That is, they'll put fat right in the middle. That fat interacts with the fat that's in the bile acid, and the water-loving part of the bile acid is on the outside. This is exactly the way soap removes grease from your hand, only this is just a different chemical that helps fat go into a water type of phase. Now, why have I gone through this incredible story? And this, by the way, this is exactly the form of fat when it's absorbed in your gastrointestinal tract. And there it is right there. These are particles in your gut. Those particles can be picked up by the lining of the bowel and carried into the blood through the lymphatics of the intestine. And there they are. They're in the blood now. Don't have to worry about them anymore. They're just going to make you happy and fatter and healthier. And they're now out of your gut and in your system. Okay. You still don't know why I'm telling you about this. Watch this. Bacteria are able to take these bile acids and make them so they don't work. And what they do is they cut off these little green things that we're seeing here, which was the hydrogen ion, the hydroxyl ion, and so forth that I showed you before. And now the water-loving part of the bile acid doesn't work. That means that if you've got bacteria growing in your small intestine, the bile acids that you're using to help you absorb fat can't work because they've been inactivated. And that's why this is, if you call it small intestinal bacterial overgrowth, you can do that. If you want to call it Sibo, you can do that. I call it an assault of bacteria on bile acids so that the dietary fat can't go into your system. If that happens, you have what we call malabsorption. If we measure the amount of fat that's in your stool, which should be about 5% of what you eat, now all of a sudden you have 20%, 30% of fat in the stool. It went in one end and out the other, and it will be a loss of calories for you. Fat has 9 calories per gram, I believe that's the figure. Carbohydrates have 4 calories per gram, so fat is an important source of nutrition. Now, how do we deal with this matter? First of all, we recognize that all of a sudden in small intestinal bacterial overgrowth, there's bugs where they shouldn't be. Now, think about it for a second. How do you get rid of bacteria when they're in the wrong place at the wrong time and making you sick? How do you deal with them? What? Antibiotics. Yep. By the way, this is the lining of the intestine. 2 more slides. I'll be right back to antibiotics because you're right. This is the lining of the intestine of a person, of a normal person, but people with scleroderma often have normal villi. They can absorb fat fine. It's just that the fat is not put in a way that you can actually pick it up. The bile acids are damaged. That's what your blood looks like 1 hour after eating a high-fat meal. You wouldn't believe that because you usually draw blood when your blood is usually drawn from people for testing when they're fasting, and after lunch your blood could look like that. It may just look like that with a little bit of fat, depending on how much fat you eat, but there it is. Once it's there, it's part of your nutrition. Okay. So the treatment to understand who's got bacterial overgrowth, we can do 2 things. One is we can think about it and say this person has a motility problem in the intestine. We know that they have scleroderma or a variant thereof. They're undernourished. They're losing fat in the stool. They're losing weight, as many of you know all about. And they're also not able to absorb fat-soluble vitamins, which is vitamin A, D, and there's a problem also with vitamin B12. So we have to be sure that they absorb enough vitamins, and the bile acid micelles that I showed you before are involved in that process as well. So we now have a problem. How do we get the bugs out of the intestine? Well, antibiotics. Let's do it. First, if you want to prove that they have bacterial overgrowth, you can do what's called a hydrogen breath test. Have anybody here ever had a breath test for bacterial overgrowth? Good. Okay, this is what's being done. You take a sugar like lactose or something like that, and you swallow it. And if bacteria start working on the lactose before that, up in the upper intestine where the bacteria are not supposed to be, you will get release of hydrogen ion into the breath. These bacteria metabolize lactose. The hydrogen ion that they produce from lactose goes into the circulation. It goes into it shows up in the breath. And here's a breath test that tells people that. Normal person, no hydrogen shows up until the product that you swallow gets down into the colon, which is several hours after it's been swallowed. In people with bacterial overgrowth, the hydrogen is there earlier. Within, I don't even know exactly what this figure is, 30 to 60 minutes, already the hydrogen is present in the breath. And what you do is you just blow into a tube. That goes into a canister which collects the hydrogen. You send it off. Somebody has to pay for it, the insurance companies or whoever it is. They usually do it. It's a pretty good test, and you find out who's got bacterial overgrowth. What we do, which is gastroenterologists, is we skip all that. We say a person has scleroderma, we know their small intestine is dilated, their body weight has gone down, their vitamin levels can be low, and we're just going to go in there and we're going to give them antibiotics for treating bacterial overgrowth. And very often it works. The first patient I told you about who got me interested in the digestive problems of scleroderma, she showed up with weight loss and exactly this, and I treated her for a number of years with periodic antibiotics, because when these bacteria grow back, because the gut is still very sluggish in its motility, they'll start having the problem again. So we have to think about all this. So how do we manage it? Bacterial overgrowth, first of all, we have to be sure there's no other cause of weight loss. Secondly, we have to make sure there's no other cause of sluggish movement of the small intestine. As I mentioned before, a tumor, strictures of some kind, narrowing, diverticula. Diabetes interferes with small intestinal motility also because it affects the nervous part of the gut. And we have to make sure those are not there. I make no assumption when a person with any disorder, connective tissue disorder, and particularly scleroderma, shows up in my office and has a symptom that I can easily ascribe to scleroderma, but it's a mistake. You got to make sure there's nothing else going on. That's my advertising for saying everybody should have a colonoscopy after age 50. Even the Commonwealth of Massachusetts will pay for it. So that's important. So get your regular care aside from what you need for your scleroderma disorder. So the antibiotics we use for this, I'm not going to go through them in detail. It's a long list. It's a little bit like drinking from a fire hose, as one of my colleagues used to call this kind of a slide. Knock off the bacteria by standard antibiotics such as ciprofloxacin or metronidazole, which is Flagyl. Some patients respond to other antibiotics, and there's a new one that's relatively new called rifaximin, which is taken orally. It doesn't have an effect in the systemic circulation. That is, it doesn't get absorbed to knock off bacteria that may be elsewhere in the system, but it stays in the small intestine. It's expensive, And we use it as a second drug rather than a first drug, but other people just go right to rifaximin and use that. You deal with the vitamin, I'll be back to that in just a second. You deal with vitamin deficiencies. I mentioned vitamin A and D as being particularly important. And if you live in New England, anybody here live in New England? Your vitamin D level is likely to be low normal or low. And after a winter like we had here, I can assure you that it will likely be a little bit low. So that's why you walk into CVS and Walgreens, you see all the vitamin D and all the calcium and so forth. It gets very confusing to people, but sometimes people do need vitamin D supplementation if they don't run off to Florida every winter. Rarely for bacterial overgrowth you need special kind of dietary fat, which I'm not going to go into, but you can circumvent this entire bile acid route that I mentioned for absorbing dietary fat by using special diets, and they're complicated, and very few people honestly need them who have scleroderma. Now I want to go back to the antibiotics for 1 second because I want to make one point. I don't know how this happened, but in the treatment of infectious diseases, 10 days to 2 weeks of antibiotics is very common. I have found out after treating probably a couple hundred people with scleroderma who have bacterial overgrowth that about 2 to 3 days of the right antibiotic can usually bring the problem under control. My colleagues don't believe me. I don't care. These people's, their weight starts going up. Their vitamin D levels can start going up. 2 weeks is like hitting a nail with a sledgehammer. You don't need that much. A drug like rifaximin may have a major effect on the small intestinal bacteria within a matter of a few days, as can the other antibiotics. So watch out for the 2-weekers. And they're out there, I can tell you. Okay. Now, let's talk about bloating for a second. And then I'm going to head right on down to the Netherlands, the rectum and anus. I see no one moving. Okay, if you have bloating, bloating is the one thing that gastroenterologists very rarely can deal with successfully. I tell the patient comes in and says, I can't fit in my clothes anymore, I'm passing a lot of gas, I have to move my desk away from my colleagues in the office because I'm passing a lot of gas. I just really feel lousy, and I do as much as I can to help them. And what we do in sequence is as follows. First, we put them on fiber supplements. I'm a very big fiber guy, by the way, and I believe very much in it. And we do that, and this is in a sequence. I'm talking about bloating now. We do it for about 2 weeks, and I often give them Miralax, which is an osmotic laxative. Later on, during the question and answers session, I want to talk a little bit about osmotic laxatives, but right now, I just tell you I use Miralax and fiber together, and that really helps a lot of people. You eliminate gas-producing foods. I think I believe it since I was in college. People say if you eat beans, you pass a lot of gas. You know what the word is, I mean, you know. But, and onions, carrots, raisins, apricots, prunes, some of those, if you eliminate them, you can eliminate a little bit of gas. If it doesn't work in 4 or 5 days, it's not worth it. One of the things when you treat anybody with anything is how long are you going to treat them? If you can find out within a day or two whether something's going to help someone, why would you start them on it and then have them stay on it and stay on it and stay on it if it's not helping? There are many examples of this. So every time you start a new form of therapy, ask yourself, ask your physician, ask your nurse practitioner, ask whoever is giving you this suggestion, how do I know it's going to work, it's working, and how do I know when to stop it if it's not working? And sometimes that's a short period of time, and sometimes it's long. Okay, and then we try lactose restriction, which is very difficult, but I think most of you know about lactose and its likelihood of causing gas problems if you have lactase deficiency. It's the perfect example of what not to do for a long time. If you take lactose out of your diet for 3 days and your bloating continues and your diarrhea continues and you haven't eaten cheese, ice cream, milk, or anything like that, and you're still doing it, stop doing it. Go out and get some milk, get your ice cream back in the freezer, and just don't do anything longer than you have to check it out. Is that clear? Yeah. And then there's a FODMAP diet. I have to discuss this at a later time today, hopefully. It's a special diet that removes fermentable carbohydrates from the small intestine. They can cause lots of gas. If you get a patient who's on a FODMAP diet, which is a hard diet to follow, and they feel better, they feel so good that they'll stay with it. If they're on it for longer than 6 weeks and their problem continues, there's no point in staying on. If their problem is helped, they won't even go off. They'll say, I feel so good now. I moved my desk back to where it used to be. My belly, my clothes fit me now. This diet has really done it for me. And I say, fine. If you don't want to eat honey, corn syrup, apples, pears, mangoes, and cherries, that's fine. That has to be, by the way, provided for you by a dietitian. FODMAP diets are very hard to figure out on your own, but dietitians know how to do it. Okay. And finally, on this point, and I'm getting to my last slide in a moment, you should keep a diary of what's helping and what isn't. Diary doesn't have to be too extensive. You get a piece of paper, and it says, bloating, passing gas, feeling full. If that gets better after 1 day, 2 days, a week, you're on the right track. Remember what's happening to you, and that way we help. We can perhaps help. Okay, finally, we're going to go to the large intestine. I got 5 minutes to spend with the large intestine. I'd love to spend 3 hours with it. It's a great organ. It really is. And it's so maligned in literature and everything. This is a fine piece of work for nature. There's a colon. There's a normal colon. Starts over here on the right side, lower part of the abdomen, goes up underneath the liver, almost up under the rib on the right side, goes across here. That's called the transverse colon. Goes down here, and there's the rectum area down there, and then out into the sewers of Boston or wherever you live. That's where the stuff goes. And that's an image, again, of how the colon is situated in the bowel. Most people don't know that their large intestine, that half of it is above their belly button. Did you know that? There it is. There's the belly button. Half the colon is above it. But everything you feel in the colon is usually below the belly button, which is a separate story altogether. All right, here we go. Now, this is a picture that I want to show you of the anus and the rectum. And I want to show you what the problem is. If anybody here has ever had incontinence or any problem holding stool in or leaking or having problems like that, I am fully sympathetic. That is the most unpleasant thing that can happen to a person. If you ride buses, if you have to give a talk, I'm standing here giving a talk, you have to worry about stuff like this. So patients with scleroderma are really burdened with this, and we try to understand it as well as we can. And I'm not even going to talk about diarrhea versus constipation very much, but I want to show you how your anus works, if you don't mind. I just discovered something. Can you see that arrow? No, okay. Right now, as you're sitting here, this is the lowermost part of your bowel. This muscle right here, I don't know if the people over here on the left side can see that. This long part of the muscle here is called the internal sphincter of the anus, of the anorectal area. This out here is the external sphincter. Now, the internal sphincter is not higher, it's just inward more than the external sphincter, which is here. Now, why am I showing you these two muscles? Because those muscles is what stands between you and stool and colon contents falling out all day, all night. I told you the colon is unbelievable. So this internal sphincter here is, you cannot change its power. You can change the power of the external sphincter. If you're in a supermarket and you have to go to the bathroom, you have to have a bowel movement. Can you hold it in? Yes, most of the time you can, because the external sphincter is a muscle that you can determine what it's doing. You can hold your stool in. You cannot do it with the internal sphincter because that is what's called an involuntary muscle. It won't, you can't tell it what to do. It's going to do what it wants to do. Now in scleroderma, it turns out that internal sphincter, and this is the problem with people who have incontinence, that internal sphincter is not working well. It should be contracted. This is anorectal manometry. I'll be done with this in just a moment. This is what a normal sphincter should do. That light green band here shows the pressure in the internal sphincter in a normal person during anorectal manometry, and that's a normal pressure. This is a patient with scleroderma. That internal sphincter is often weak. And it's weak in the same sense that when you have reflux esophagitis, the lower esophageal sphincter is weak. It's weak because the small intestine cannot move, as we just discussed in people who have bacterial overgrowth. And it's just another sign of the gastrointestinal tract suffering from a problem of not enough muscle strength, which is really begins with a nerve problem in scleroderma, and eventually the muscles lose their strength. I show you this because I want to tell you that anorectal manometry, which you can have done, and it's now being done in most major medical centers, is a very useful way of figuring out what's going on if you're leaking stool, if you have constipation, if you feel full after you move your bowels. These are all things that can be determined by anorectal manometry. And I would encourage anybody who's having this problem to consult your doc, or have them refer to a center that does this manometry. We do this. We do about three of these a week in our hospital. They're done by my GI colleagues, and they are really helping us a lot. But if you know how this all fits together down here, you'll already know probably more than you did before about why leaking can occur. And we can expand on this as we move on through the day. Okay, I'm going to finish. Anybody who wants to contact me, I answer telephone calls. This is my private line. I just gave it to one of my former patients here, and she said she couldn't get a hold of me, and I said, you didn't call this line, because I always answer that myself or pick up the messages. I'd be very interested in talking to anybody and helping you and directing you to the right place. Do I have time for a quick question? No.
Dr. Plaut, before you leave the stage, we crafted 10 minutes of question time just in case.
Good.
Because as you recall from our last presentation from Dr. Plaut, lots of questions came up, and I think that if in 10 minutes we can answer a few questions that have come up, I'd love to ask you to stay for
Absolutely.
a bit. Okay. So while we don't have a microphone to take through the audience, if you have a question or something you'd like to address with Dr. Plaut, now would be a good moment to do it.
I will review. Yeah, the question is, do taking antibiotics change the microflora in the intestine generally? This is absolutely the case. It does. There's two good things that happen when you take the antibiotics for bacterial overgrowth. One good thing is, as I mentioned, those antibiotics are very successful in knocking off the small intestinal bacteria, which you don't want. And the second thing is, the bacterial changes you make in the large intestine usually are corrected, as the bacteria that are supposed to be living there usually come back rather quickly. There can be problems such as C. difficile, antibiotic-associated diarrhea, and so forth, which I don't have time to go into. But essentially the bowel flora, those billions of bacteria, do correct their numbers and types very quickly. Please. You know, this is a little bit like asking whether I recommend religion. Because I think that, I don't mean to, I'm not going to knock probiotics. They're very interesting things. I think that the probiotic field has a lot to answer for. They cost money. Some of them are dead, and probiotics should be living bacteria. And there are probably 1,000 papers a year published in at least the English language literature on the advantages, success, and so forth of probiotics. I still have not been convinced that they are helpful. However, I will tell patients, again, try them for 2 weeks. If you don't find a difference, stop them. Don't keep buying them. And there are some that are good. I've got to put in a plug for one of my colleagues who developed the drug called Culturelle, which is a probiotic that came out of our institution. We know those bugs are living. Whether they will populate the intestine for a long period of time is a little less certain. Yogurt is a probiotic. It's a living organism, and if you eat yogurt every morning, you're eating living Lactobacillus rhamnosus or something like that, and it's they're alive. So I would love to answer your question definitively, and I can't. Please. Sorry? But I don't hear what the question is about the esophagus. Oh, you know why? Because I usually talk a lot about the esophagus. And I don't mean to ignore the esophagus at all, but it's the most important organ for problems in patients with scleroderma, and I'm aware of that. Very briefly, I'll spend a minute on it, and I could spend a much longer time than that. The esophagus motility in the patient with scleroderma is sluggish. If you measure this in anybody who has scleroderma or one of its variants, even if they don't have reflux esophagitis, even if they don't have chest pain or regurgitate, about 90% of people with scleroderma, especially the ones that have Raynaud's phenomenon, will have abnormalities in their esophageal function. The problem is, again, nerve problem in the esophagus first, then the muscle becomes what we call atrophic. It doesn't work very well, and then any acid that goes into the esophagus has trouble getting back down into the stomach. And that's where the big problem is. So I strongly encourage anybody who has scleroderma to pay close attention to what's happening with their esophagus, and even if they're not having symptoms, I still worry about them because I know that that esophagus is not moving properly in most people. And so we sometimes just put people on therapy with proton pump inhibitors or ranitidine or one of the other H2 blockers to prevent acid formation. This is a complicated subject, and I usually spend a long time on it. And I decided to move a little further south in the gut today. But I'd be very happy to talk to you about this anytime. Please. Yeah, so the question is not just protonics, but any of the proton pump inhibitors? Yeah. Yeah, there's a bunch of those drugs, protonics, omeprazole, many kinds. Yeah, those drugs will increase to a very small extent the number of bacteria living in the stomach, because acid is a very good suppressor of many bacteria, and when you take these drugs at full dosage, your stomach is kind of neutral pH rather than acidic, and so bacteria can grow there. And we know this based on all kinds of studies that have been done in intensive care units where patients are on proton pump inhibitors like the drug you mentioned, and they can get pneumonia because they're aspirating stomach contents. With respect to downstream, do these drugs have any effect on bacterial in the small intestine? Not very much. Here's why. The acid that usually goes into the small intestine in a normal individual is immediately neutralized by base, which is coming from the pancreas and other parts of the gut, which causes the small intestine to be relatively neutral pH. So it's movement in the intestine, not its pH, that makes a difference. By pH, I mean its acid content. I hope that clearly answered your question, but possibly didn't. Down below comes up?
Yeah.
Belching?
Yes.
Yeah.
Is it the same thing or is it a different problem?
Yeah, well, it is gas. Let me tell you something about bloating. This is a sensation. It's a sensation people have. They say, my tummy is really big. And when you examine them, often, you don't find the abdomen as being big. And there was an investigator at the University of Minnesota many years ago who actually determined the gas volume in the gastrointestinal tract of these people by dumping the whole patient to the neck into a tank of water and measuring displacement of how much water that was. You have to be a naval architect to understand what he did. But in fact, many people do not have high amounts of gas. It's just in the wrong place. If there's a lot of people that do a lot of belching, sometimes that is what we call a behavioral problem. In other words, it's something they've learned to do to relieve a symptom that they've got, and they just keep doing it. And the gas that comes out is not usually methane or hydrogen, it's air. So the answer to your question is belching. What's the other end called? I can't remember. That is the same. That's one part and parcel of the same problem. Well, I'm glad. Thank you very much. Well, first they have to know it. And of course, it's a huge incentive here because I do this retail. I do it patient by patient. But you come here and you can talk to a lot of people at once. So I'm ready for that. But thank you. One more question? Oh, sorry. Yeah. So if somebody comes to me with bloating, person with Scleroderma or someone, yeah, well, that would immediately come to my mind. Yeah. Now, and then I would, again, just to reiterate what I said before. That's what reiteration actually is what I said before. What I would do with a person like that was say, does this person have another problem related to bloating? Could this patient have celiac disease in addition to scleroderma? Could there be some other problem? Once I'm satisfied with that, I got two choices to make. One is, do I do breath test? Or do I just treat them? And I must confess to you here in this Scleroderma church that I treat them with antibiotics, short courses, and find out whether it helps them. That's what I do. Okay, we're all set. Thank you.
Thank you, Dr. Plaut.
Here, I'm gonna give this to the expert here.
Thank you, Dr. Plaut.